HS Kim, 지훈 강, 민주 한.
Okay.
우리 조현정 교수, anesthesiologist. 김영민, specialist from Boston Scientific. 박찬순, echo or specialist. 김동구. Okay, let me introduce the final results of previous CTO case, the second CTO case today. Slide, please. Okay. This patient was, this film was 2 months ago, failed by young doctor. Proximal LAD CTO with collaterals from RCA to LAD plus. Thus, I tried first retrograde approach today. It looks very many septal channels, but 1 hour struggle, I failed to find the appropriate retrograde channel. As you can see on the right side, the distal tip is bifurcation. It is bad thing for antegrade approach.
Dr. Kim,
Yeah?
sorry to interrupt, but this is structure heart theater, and please your presentation as brief as fast as possible.
Yeah, because in previous session you were chair, thus I report to you the final results.
Yeah.
plus, then the third channel was not found. Plus, thus I did CISO body wire technique using 3 wires. And 1 hour struggle, I finally find the true lumen plus, then I balloon plus, stenting plus, Okay, this is final results of the previous CTO case. Let me introduce the 4th case today, second TAVI. TAVI slide, please. "84-year-old male, worsening dyspnea. Interesting finding is he has dynamic obstruction at mid-LV and LVOT, plus. Surgical risk is intermediate, plus. X-ray ECG normal, plus. LV function is normal, but severe LV concentric hypertrophy with obliteration of end systole, plus. Severe AS, plus. Severe dynamic obstruction at mid-LV and LVOT. Baseline 25, mid-LV gradient, increase up to over 100 tau, plus. Thus, we considered alcohol ablation to target LVOT muscle, but as you can see, the first septal branch is too small, and there is no obstructing muscle at LVOT. The surgeon refused to do operation, urged us to do TAVI. Thus, we decided to do TAVI. Plus, valvular calcification is moderate, plus. But annulus LVOT calcification is very ugly. Size is about 24. Heavy calcification, NCC and LCC. Plus, sinus valsalva large enough, ST junction 30 millimeters, plus. Coronal height 13, 17, ST junction height 20, plus. Septum is a little bit short, 4.7 millimeter, plus. Fricassa view is very important, it is good, plus. To summarize measurement, 20 by 28, mean diameter is 24. There is no other issue except for the dynamic obstruction and calcification at annulus that extend to LVOT, plus. I chose accurate nail plus because there are calcium chunk on annulus and LVOT, safety is important. Leakage issue is also important. Additionally, dynamic obstruction at LVOT and mid-LV, plus. When I decide one valve out of 4, I always consider 9 clinical conditions. This patient has risk of LVOT tear due to alveolar calcification, risk of leakage due to annular calcification, a risk of AV block, short membranous septum. Thus, such kind of condition urge us to select accurate nail. Plus, radial force at annulus after full deployment was similar between accurate and evolute. Most people misunderstand that evolute is stronger than accurate nail, but that is only initial expansion, initial deploy process. After full deployment, annulus level radial force is exactly the same. Plus, additionally, accurate nail has active paravalvular seal. Plus, the seal is redundant, thus it may expand when regurgitant flow meet, which is in contrast to the adherent perivalvular seal in evolute. Thus, they call it active seal. Good for prevention of leakage. Plus, the second issue is dynamic obstruction at LVOT and mid-LV, leading to suicide left ventricle after TAVI. Thus, we are keen to maintain preload as well as afterload. Okay, let me show the present progress. Angel, please. Puncture under fluoroscopic guidance, plus, 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 plus. Double tracing. Okay, let me show the hemodynamic data. A severe pressure gradient. Okay, please discuss, and we are going to proceed.
Okay.
Procedure by inserting.
Yeah, thank you, Dr. King.
Yeah.
Let's start the discussion about the selection of a valve. Actually, this challenge is coming from the dynamic obstruction and the alveolar calcification. So which the valve is the best option for this? Anyone can answer?
Jonathan from Singapore. I think in this case, there's quite severe LVOT calcification. So a balloon expandable valve is still okay if we dilate it slowly and gently, but maybe a preference would be towards a self-expandable valve. I have no experience with the accurate, so in my center, we will probably use an evolute for this case.
Okay, so the risk of the rupture is really, that we are really afraid of. So all members agree with the self-expanding valve?
Choose a self-expanding is reasonable, but if you want to use balloon expandable, you should start from underfield and make optimization afterward.
Yeah. Okay.
This patient is very severe horizontal aorta. Thus, if you meet horizontal aorta, you can choose sapien rather than evolute or Navita.
Yeah.
Accurate theory is really a good option because during deployment, we always push the system a little bit. That always bias the system toward great curvature and horizontal.
Yep.
Thus, in horizontal aorta, if you try accurate nail, it is very easy. Let me show today. Okay, we are going to do ballooning. 21 millimeter balloon. 잘 안 보인다. Okay, 자, pacing, inflation, deflation. 당기지 말고. of
Very quick. Very quick balloon inflation. So, any preference for the Evolupro or Ecrineo? The same. So actually, many people tells that says the Ecrineo have the weak radial force, but the data show, Dr. Kim showed that this is quite similar.
Thus, most people misunderstand. Force is different, but that is only when the opening.
Dr. Choi, Seung-Hyuk Choi, you always told me that the Ecrineo is weak.
Yes.
Weak, no, opening force is very soft.
Yeah. So I understand that expanding force is weak, but radial force is good. So we have to, the exact site of deployment is very important. And another thing is in LVOT calcification, huge calcification increases the risk of rupture. So, but actually, if we select that Ecrineo 2, we have to pre-balloon. So balloon sizing is very important. Dr. Kim, so what is the balloon size?
25 millimeter.
4 millimeter.
25 millimeter valve with 15% oversizing.
Okay. So you agree that Ecrineo, you always pre-dilation?
Yes.
Yeah. That's one difference between the Evolve Pro and Ecrineo, right?
Okay, let me progress the procedure.
Okay.
This patient, so
One of the
valvular
beauty is,
calcification very small. Alveolar
it is
calcification
easy
heavy,
to
but
make
so
the commission
valvular calcification
alignment.
small. So I think Ecrineo is good choice for in this patient.
Because calcification is not so severe.
Yeah,
and the
valve calcification.
valve
is small,
calcification is not so severe. Okay. Still, people are worrying about the radial force, how to get Ecrineo. Anyway.
So
Can you
well
see the
expanded
visual?
radial force is good, but
That is
so
only
initial
appear on the
force
left
is very
side,
weak.
so
The
I
Ecrineo.
Initially, the
Hardcore
radial force is weak
orientation.
because that is the reason why we start with the pre-dilation and Ecrineo, right?
Usually,
I think the anchoring portion, I mean the low frame,
Yeah.
the radial force is okay.
Yeah.
Yeah, the upper portion because of the metal is not that much, so the radial force is less.
The opening radial pulse is weak, but the final radial pulse is same to laboratory. Usually, company said that.
Okay.
Well, please believe my slide.
Yeah.
Opening pressure is only
We are
different.
talking about the initial radial force and the final radial force. Yeah. It's fair to say. Yeah. So I believe that many of the panels and the audiences are not familiar with the Ecrineo valve, and please make us more comments during the procedure if you can.
쭉 해가지고 밑에서 다시 한번 할게. 브레이딩이 된 모양인데.
Yeah, when it comes to coaxial alignment, this like a horizontal aura.
right.
The acute neo, as you know, that the top-down deployment. So that kinds of deployment strategy, it's better than this like horizontal aura to get the good axial alignment.
So basically, that kind of action is similar between Evolve Pro and Ecrineo. Is that right? If I understand correctly?
No. Different.
Different?
Yeah, different.
Oh, different.
Yeah.
Okay.
Totally different.
Ecrineo is coming from the top to down, right? Yeah. Okay. Yeah. This the advantages for the alignment in the horizontal aorta.
Yeah.
Okay.
Okay.
Maybe we can also add that there was a randomized comparison between the two valves, the SCOPE 2 trial, where the first generation of the valve was used. So this is the second generation with improvements, that's for sure. In that trial, there was less pacemaker implantation with accurate neo, but more paravalvular leakages. And in the end, it was not non-inferior to Evolut. But with the second generation, they fixed many issues.
So we start to release. Before start to release, we have to check the commission. RAO. you can see the one free set is anterior side. 다시 because this commissure line is good. You can see the commissure on both sides, right? A little bit prominent on the left side.
Yes, I think so.
Then we are going to a little bit turn counterclockwise. Okay, I can.
Yeah, it's equal.
Similar?
Yes.
Okay. Free cell is similar in both sides. Test to check the left. Okay, depth is good. Just start the first phase of release. Upper crown.
Flowing. 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 Flowing.
Test. A slight downward movement. It is unusual, but it's okay. Just see that? Just I push the wire a little bit to elevate the system once again. Also okay. Just release the arch.
Dr. Kim, in this situation, how deep can you go?
So you're trying to align the inferior part of the marker on the annulus, is that right?
Yes.
Okay. So it's a little bit deep, right? And ventricular. No? A little bit ventricular, is that right?
Okay. The depth is a little bit different depending on the size of the valve. A small valve, the marker should be on the annulus plane. Middle size, like this, marker should be at the annulus line. And the bigger valve, marker should be a little bit low, that annulus line. But I'd like to implant a little bit deeper because this is supraannular design valve and the low crown pressure is very soft.
Okay.
Versus the chance of AV block is very low. So I prefer a little bit deeper implantation of acroneal. I like this depth. Before final release, I will show you the depth of the valve. Just see that? It's good.
Yeah,
Then
a little bit
pacing, we are going to release the final step.
So you
Okay,
think
John?
the risk of complete AV block is not that high
Repeat.
in this patient?
Off.
Okay, yeah, this is a moment of truth.
Okay, just then I would like to centralize the delivery system by withdrawing the supply wire to avoid the scratch between sheath and the belt frame. Okay, maintain wire. Okay, capture. 조정하고.
I can see that the frame size, the frame opening is very large compared to Evel Pro. The coronary access is quite easier for the acroneal. I found some bifurcation lesion in the LAD.
As you can see, the horizontal aorta, it deployed proximal first. Thus, after release of archie, the system is well aligned with aortic axis.
Yeah, quite impressive. So you think the alignment in the horizontal aorta is advantageous for the acroneal, right? Acroneal is better than Evel Pro in the horizontal aorta. Is that right?
Yes, that's right.
Okay.
Yeah, I believe.
Yeah, I believe. Okay. Yeah, I can see that. Yeah, it's quite impressive. So
Yeah,
usually Evel Pro, the alignment is quite difficult.
wire is centralized. Okay.
And the upper chrome is
First, we'd
softer,
like to
so
see-
you won't hurt the outer.
Yeah. We have renowned Dr. Sung-Jok Park here, and any comment you like? I'd like to invite any comment from you.
Right. Personally, anesthesia, I'm not familiar with the self-expanding. So, Dr. One is the very procedural deviceal advantages compared with balloon expandable, compared with the other self-expanding, Evolut R something. Could you explain that one?
Actually, we have discussed about that. Actually, the first choice of self-expanding versus balloon expandable, they are worrying about LVOT rupture because of the LVOT calcification. I don't know. I didn't choose. And if people agree with self-expanding is better, more feel safer than the balloon expandable. Secondly, this is the ENCORE Neo is better than Evolut Pro, possibly in the alignment in the horizontal aorta. So this is very good, very nice learning point.
Okay.
In terms of radial force-wise, is absolutely less than the balloon expandable. So, how frequently do you use in terms of a post, device stand, post stand, balloon inflation?
Dr. Kim, Dr. Park asked you that how many times do you use post dilation for the ENCORE Neo? Is it higher than other valves?
Of course.
Of course. Why is that? So radial force is similar.
We'd like to, of course, I'm an aggressive interventionist. Average about 20 or 10% of ENCORE case post balloon, but 50%. How many?
The post balloon frequency is higher for ENCORE Neo compared to other valves.
40%.
In our institute, the incidence post balloon is about 40%. Average 20%.
Average 20% and 40% for ENCORE Neo.
Yes.
In our institute, 40%, but average 20%. Because in this case, there is no leakage. Most people don't do post ballooning, but we do. Considering the round shape would be helpful to maintain longevity.
Please tell me about the superior portion of the valve. It is well expanded. It's not a problem, right? Anyway, this is self-expanding.
Okay, rapid pacing. Balloon.
Yeah, what's the size of a post balloon?
20.
23.
23. Yeah, same balloon, right?
22. Okay.
Same balloon, bigger size.
Bigger size.
The pre-deal was 21 millimeters.
Yeah, 21 for predilation,
The
23
company
for post
recommend
dilation.
24 based on median diameter, but I'm a little bit conservative. Yes, I always do.
You said you're aggressive.
But they are very aggressive.
Yeah, I can see that valve is expanded further.
The one thing in this point, the three arches are evenly distributed. That means, in tricuspid, that means good commissural alignment. 아래로 카드기. Flashing to make here. Here we can see in the cusp of left view flashing. You can see one pulse on the right, two pulses on the left. two posts on the left not overlapped, a little bit separated. Thus, I guess the alignment is not perfect. It would be about 10 degrees, included in categorized as good alignment. There is no problem to engage coronary ostium in this condition. That is one of several beauties of accurate neo. 다시 프리카스피.
So, Dr. Kim, we have 1 minute left to move to Japanese center. So,
프레셔가 이상하네.
하나는 다이어서
네, 아직 안 바꿨어요. 다 있으실 줄 알고.
아, 다 있어. 오케이. 네.
Dr. Kim, the commercial post is really high in accurate neo. So do you think future TAVI in TAVI, the leaflet overhang will be an issue?
Yeah, definitely. But as I mentioned before, yesterday to you, it is easier to implant Sapien in faded accurate than implantation of Sapien in faded absolute, because we can definitely see the upper margin of leaflet in accurate nail, the central post. But absolute, there is no mark to indicate the upper margin of leaflet. Thus, they're very similar to each other, but I think it is easier to implant TAV and TAVR Sapien in the failed accurate than failed absolute.
I can see that the PVL is not on the mild, but the alignment is not so well aligned in this view.
But when you consider the annulus calcification and alveolar calcification, such kind of results is really wonderful. It's very safe.
Right.
But still, effectively block leakage, even though there is huge annulus calcification and alveolar calcification. No concern about conduction abnormality. The best results in terms of
I agree with you. So
Okay, this is hemodynamics.
Yeah, perfect.
140, 145, 90, 95, 55, 15. The R index is about 30. New index proposed by our team is 3.6, suggesting negligible regurgitation. Oh, no regurgitation.
Okay. Would you like to assess the PVL with echocardiography?
Okay, we can show you the echocardiographic finding, TTE. Dr. Park, would you please explain?
Yes, and in this echocardiographic imaging, you can see two kinds of flow acceleration, and one is caused by a moderate degree of mitral stenosis, and one occurred at intra-aortic cavity during end-shift tour. And when we evaluate the presence of dynamic obstruction, we can find some subtle flow acceleration without hemodynamic significance. And we cannot perform provocation maneuver during the sedation, but I think this is very good result after TAVI.
As I mentioned before, the patient had dynamic obstruction at mid-LV level, and at that time, the baseline peak pressure at mid-ventricle is peak velocity is 2.75. Now it decreased down to half, 1.75. Thus, suicide heart is not a concern right now. And let me review this case. The first, we have to check the level and position of free cell to make the commissural alignment, plus then cautiously we deploy the upper crown. plus. Then check the level and plus. Then stabilization arch is released, plus. That is helpful to make the coaxiality between the device and outer root same. At this point, we can see the post position well distributed, meaning good alignment. Once again, here we go. Plus, then under moderate degree LV pacing, plus we finalize the release step by releasing lower crown. Plus, and we perform a post-ballooning, plus. Then this is a final angiography. In the areocaudal view, we can see the one post on the right, two posts on the left, plus. Here, three-cusp view, three posts are equally distributed. Regurgitation, negligible. It is better results than we expected, considering big annulus calcification and alveolar calcification.
Yeah, very nice considering the alveolar calcification. Very nicely done.
Okay, this is the final image.
Dr. Kim, during the deployment, if the location is really too deep, are there any tips and tricks can adjust it?
My personal tip is just push the suffering wire and a little bit pull of the device. It is not difficult to elevate the level of device, but when the upper crown is below the calcium chunk of valve leaflet, it is very difficult because just the open upper crown is kind of touch the calcium chunk. Thus, it is very difficult to elevate the level. Thus, in the presence of heavy calcium chunk on the leaflet, you pay attention to maintain the upper crown level just above the calcium chunk.
So can you show the echocardiography so you cannot see any the PVL, right? So sometimes we are facing a very underestimation of the PVL in the echocardiography. We can see a negligible but minimal to mild PVL in the angiography. So actually, I'm not sure about that. What is the most accurate measure? What is the most clinically important measurement of PVL, echo, and angiography? So there's so different. The air index so different.
We prefer to use echo.
Yeah, if you like to just echo, you like to underestimate the PVL.
But sometimes I do think that has something to do with the contrast injection.
First, evaluation of leakage is a little bit complicated. We have at least three measures to evaluate the grade of leakage. First, hemodynamic measurements such as the aortic regurgitation index, but this is also confounded by many factors. The second is aortography, but there are really variability. The injection,
Right, yeah.
velocity, injection volume, site of injection. The third, echocardiography, is also not so reliable because when you cannot see, you miss the regurgitation, Just this interpretation is no regurgitation. Thus, I think meticulous methodology of echo should be a kind of basement for us to understand, to believe the echo interpretation.
Actually, you injected a lot of amount of contrast. I believe that this is a negligible amount of PVL, but sometimes some centers they use a very small amount of contrast. So, there's a report of a mild PVL. There's quite a lot of variabilities.
Mm-hmm. So most interventional cardiologists don't like the leakage.
Yeah.
After TAVI.
Don't like to show the leakage.
All right.
So we really consider such kind of instinct. Because in our institute, we are really try to see our faults. That is the basement for us to improve further in the future. Because we'd like to expose our kind of bad thing or bad results. That attitude is very important.
Any comments, further comments from the panel? Dr. Park?
Right. Anyway, Dr. Kim, congratulations. It's really, very much educational case too. And so, anyway, if you look at any large registry data, TBT data, so compare with the balloon expandable and self-expanding, clear things is still the PBL rate and the frequency of permanent pacemaker rate is a little bit higher, right? If you look at the in detail database, the most important predictors is calcium amount, right? Based on the data, even in the balloon expandable, self-expanding. And so 2 cases, Dr. Kim, you've done post-balloon dilatation. The meaning is it's totally different with the terms of radial force, circularity, even in the, especially for the high calcium cases, actually the self-expanding is not too much circular. In terms of a circularity concern is less than 50%, so we have to do pre-dilation, post-dilation, etc., right? So what I'm talking is still any type of procedures before the device selection, before the size selection, meticulous CT evaluation in terms of a location of, right chronicus, left chronicus, sinus ratio, how much, push up the calcium amount, etc., lots of detail, meticulous CT, especially calcium amount and annulus size evaluation is very important. Just what I want to comment on.
TAVI is all about the planning, right. That is what Dr. Kim has done before this procedure.
Regarding the comparison between SAPIEN and Evolut, of course, circularity is inferior in Evolut, but actually it is supraannular design valve. Thus, it is not so eccentric at the level of functional leaflet level. In terms of acroneal, it is also supraannular design. Thus, at the active functioning leaflet level, the roundness is not so different from the SAPIEN. Circularity is an important factor, but more important factor is orifice area. That is really related with bioprosthetic valve degeneration and longevity. Thus, I think if it is indicated, it is complex to deploy. Simplicity is SAPIEN. Thus, most physicians prefer SAPIEN because it is easier. But if you are accustomed to such kind of valve, you have a lot of patients who are really indicated for this valve.
Circularity and effective, valve area concern is not too much different in case of small calcium and moderate calcium, right? So based on our data, just only, Asian, Korean, 2000 based on the data, look at this. more than 90% of a patient has a mild calcium, moderate calcium. Anyways, in some cases you're going to treat it with heavy calcium, so 1,600, something like that. However, small calcium amount, we cannot make any difference in terms of balloon expandable, self-expanding concern. However, heavy calcium, in terms of circularity concerns, how much radial force for the calcium valve, something, it's totally different things, right? So most of the cases, live demonstration cases, proctorship cases, almost all cases is a very small calciums, right? We don't know about any concern. Just my personal kidding, right?
Yeah. Yeah.
Most
Dr.
of
Kim, he's not
patients-
blaming you.
No, most of the patients have small, moderate calcification. In that population, really effective orifice area or residual pressure gradient is very important factor. In heavily calcified patients, SAPIEN is really a kind of concern for most of the physicians to actively deploy, to optimize the inflation. Thus, in any way, I think SAPIEN is very simple, easy to deploy. It is good. And it is really the first choice of valve to consider future TAVI and TAVI. But a substantial number of patients may be treated with other types of valve.
Yeah. Anyway, the never-ending story about the balloon expandable versus self-expanding, and so all agree that the planning is the most important part of the TAVI procedure, and the CT is in the center of the planning. So I agree with Dr. Park. And this is a highly calcified LVOT that you have very nicely performed the procedure with a very negligible PVL with a full amount of contrast. Congratulations. And, can you conclude the case for us? Just one minute?
I've done 4 live cases today, 2 CTO, 2 TAVI. Thus, I'm a little bit tired.
Right.
Thus, I'd like to conclude.
You look like tired.
Live today. Thank you very much.
Thank you. Nicely done. Nice case.